On behalf of Hospice of the Piedmont, welcome to the E-Series, an educational webinar aimed at engaging our community, exploring relevant topics, and educating about ways to connect with our organization. My name is Ryan Biagini, and I am your host. Today, we begin our next installment of the E-Series with Exploring Our Community, Defining Health Disparities, a conversation between CEO of Hospice of the Piedmont, Trent Cockerham, and Dr. Goldie Smith Byrd. Trent joined Hospice of the Piedmont in 2013 as the organization's third CEO since its founding in 1981. He has 25 years in healthcare leadership. Most recently, he led the organization in navigating a successful merger with Hospice of Randolph. Thanks for being with us today, Trent.
My pleasure.
Our guest, Dr. Goldie Smith Byrd, joined Wake Forest School of Medicine in 2018 as Professor of Social Sciences and Health Policy and Director of the Maya Angelou Center for Health Equity. Dr. Byrd conducts research on the genetics of Alzheimer's disease in African Americans. Her work is published widely, and she has presented in 9 countries around the globe. She addresses health equity through research, efforts to create institutional trustworthiness among underserved populations, and increasing diversity in the biomedical science workforce. Dr. Byrd won the prestigious Presidential Awards for Excellence in Science, Mathematics, and Engineering Mentoring at a White House ceremony in 2010. She currently sits on equity panels at the National Institutes of Health, the North Carolina Institute of Medicine, and pharmaceutical companies interested in diversity and inclusion. Thank you for taking the time out of your busy schedule to be with us today, Dr. Byrd.
Thank you, Ryan. It's my pleasure to be here.
In just a moment, we will get the opportunity to sit in on a conversation between Trent and Dr. Byrd as they unpack what health disparities are, answer why they exist, explore whom they affect, and discuss how they impact our community. During today's conversation, if you have any questions, please type them into the Q&A section, which you will find at the bottom of your screen. We will set aside time to address these at the end of the session. You may also choose to type any additional comments in the chat section. Now, without any further ado, I hand the discussion over to you, Trent.
Thank you, Ryan. And Dr. Byrd, thank you so very much for joining me today. I appreciate the opportunity to have this really important, I think, an incredibly timely conversation about an incredibly important topic, and that, of course, is health disparities. You know, before we begin and sort of launch into that, I would be remiss if I didn't give you an opportunity to talk a little bit about the Maya Angelou Center and what the Maya Angelou Center actually does.
Well, thank you, Trent. It's my pleasure to be here today. And I'm always happy to talk about the Maya Angelou Center for Health Equity. The center has been around for quite a number of years. I think it was born in 2002. And today we are expanding our footprint in the community. Our pillars are outreach and education, of course, equity research, pipeline programming and training. And we're just planting the seeds for a social justice and health policy arm for the Maya Angelou Center for Health Equity. So we connect with many different communities, and particularly communities that are underserved. Wow. So thank you very much for the invitation to be here today.
Yes, of course. So, you know, as I was thinking about what our conversation might be today, I did a little bit of research on my own about health disparities, and I'm astounded to have learned that Kaiser Family Foundation Center research released a research policy paper not too very long ago, so it's very timely, about a year ago, that said estimates are that health disparities account for about $93 billion, and that's with a B, dollars in excess medical care, and another $42 billion, also with a B, dollars in lost productivity per year, as well as economic losses due to premature deaths. This is a gargantuan problem, right?
Absolutely.
And so as I think about wrapping my mind around that and the reality that we all have some share in paying for that, right? I mean, we are all affected by that. I think we have to back up from that, though, and first understand, what is a health disparity? I mean, just simply, what is it?
So a health disparity is a measurable difference in health status between people, those things that are related to the social and demographic factors such as race, gender, income, geographic region. So those things that influence us every day that create this measurable difference in terms of health status or health outcome.
And it sort of, it spans the width and breadth of an entire population, right? I mean, not just, it is segments that are disproportionately affected, but it affects sort of every segment of our population.
Absolutely.
In some ways, right?
Absolutely. Sometimes, people think about health disparities as those differences between races and ethnic groups, but you're absolutely right. It's much broader than that. It could be education. It could be, just race, sex and gender. It could be where people live, environmental stressors, and of course, that these just expand our culture.
And so is it fair to estimate that, those social determinants of health that you just mentioned, that those all sort of conspire, for lack of a better word, to sort of what we see as the end product is really the health disparity, perhaps, and that manifests along an entire spectrum of life, I suspect, from very young to very old.
Absolutely. As Ryan said in my introduction, I conduct research in Alzheimer's genetics in African Americans, and even within populations, these social determinants may differ. But when you have communities that are distressed and systems that are distressed, you will get disparities in health and health outcomes. One of the recent things that has been exciting to know about in the dementia world, which Alzheimer's is a dementia, is that 35 to 40% of cases could be prevented if we could improve those social determinants. And that is hot off the press. That came out just this past summer. There was a Lancet commission that talked about it, but then the update this past summer was that at least 40% of the cases probably could be prevented if we could improve these social determinants.
And when we talk about social determinants, that's astounding, by the way, but when we talk about social determinants, I suspect we're talking about a lot of things. We're talking about access to care, but more importantly, we're talking about even just access to nutritious food, and access to other things that sort of we all might take a little bit for granted if we're not affected by a disparity.
Absolutely. So when I'm presenting on this topic, one of the slides that I like to show is one from the CDC that shows that only 20% of health outcomes comes from actually the clinical side.
Wow.
That leaves 80% of positive health outcomes comes from environment, our living conditions, our socioeconomic status, and basically these environmental and behavioral factors. So absolutely, it's everything from the time we're born, actually before we're even born, before we're born, and then in the environment that we are placed in once we are born, all contribute significantly to health outcomes.
Wow, that's really interesting. So we've talked a little bit and sort of touched on this a bit, but why do health disparities exist?
Well, disparities exist if we focus on those social determinants. It didn't just start. It has been laid bare since COVID. We've heard quite a bit about social determinants or social drivers, but certainly the racism in our country has contributed significantly to that. And when you think about that, it's not only slavery within African Americans, but it's also Native Americans and how they got started and what has happened in these communities, Hispanic Americans. It's just been a trail of separations and casting, if you will, and then that has created gaps in socioeconomics, which creates gaps in health outcomes, health care. And so these are things that we need to think about as professionals, as community organizers, as community-based organizations, as our policymakers. These are the things that will have to be adjusted on a broad level in a very complex way. So social determinants didn't come overnight, and they won't go away overnight. So we've got many systems involved in creating this very difficult situation we're in right now.
Right. So when we think about it, you've touched on this too. You mentioned a lot of disparate populations, not just African American, Native American, the Latinx populations. You know, I'm also reminded that, you know, we live in a state that varies from very urban to incredibly rural.
Absolutely.
Where people who live in incredibly rural areas of the state, or even our own region, because we have, you know, areas within our own region that are incredibly rural, and our own organization serves a number of rural communities. They too are affected by health disparities. Is there a common sort of theme that runs through all of those, sort of without regard to race, ethnicity, gender? I mean, those are overlays, but is there one sort of undercurrent that sort of affects all of them the same?
Yes, so you're absolutely right. I mean, if you look in rural North Carolina or rural America, you know, you rural Appalachia as an example, and so many of those are not people of color, but they are in distressed areas. They're located distant from medical centers. They are located distant from, they may or may not have appropriate broadband where they can get information as freely as others. They may not have the resource, certainly they won't have the resources and services, specialty care as others. So we're talking about, from my perspective, socioeconomics.
Yeah.
At the end of the day, we're talking about access and socioeconomics.
Yeah.
And so you're right. They're not just people of color, but they're all of those groups that we talked about.
And you talked a little bit about literacy, and let's have a brief conversation, if we could, just about health literacy and how people who are affected by health disparities, or maybe affected by social disparities in general, how are they affected by literacy, disaffected by literacy, and how do they bridge that?
Right, so they absolutely are affected by literacy. You know, the good thing about having a mobile phone is it is a small computer. So I do believe literacy has improved because of the smartphone. However, in some areas, particularly in those rural areas that we were just talking about, you know, broadband access is huge, and there are gaps in that. And of course, that's being played out even in our school systems. There have had to be major adjustments there so that children and students in those areas will have access to get their work done. And we do worry about how their well-being, even in the city, but certainly in those rural and distressed areas and underserved areas. And so yes, literacy is huge. It is difficult to really make behavioral adjustments and environmental adjustments if you are not aware. And I think it takes institutions like all of ours to help bridge some of that gap. I can tell you awareness is a huge component of what we do here at the Maya Angelou Center for Health Equity, particularly around COVID and other diseases, not only acute diseases, but chronic diseases. We've done an enormous amount of improving awareness about testing and resources and of course, vaccine uptake. So
Yeah.
literacy is huge, yeah.
You know, it's so interesting to me. I never would have imagined, as the internet came into existence, you know, many years ago now, that we would even be thinking about that as both a barrier in terms of access to, and even a potential solution to healthcare access, or even healthcare literacy. I mean, that's an interesting notion that I hadn't, you know, thought about until this conversation. I mean, that's really.
Absolutely. And I tell you, you know, folks who conduct research as we do and who are engaging, one big area that we need to think about is how we produce materials for underserved communities. I mean, if communities are disproportionately undereducated, and they don't read our journals. And so I was just in a conversation this morning with a group conducting a COVID study, and I said, we've been doing this study for a year now. We need to get this data back to the community, but in a way that the community can understand it. So if we are writing at a 12th grade level, but the people we need to talk to are at an 8th grade level, then we have miscommunicated. So health literacy is an area that we as persons and organizations who create materials should be much more aware and cognizant of those gaps in education.
Right. This is fascinating. So we've talked a bit about disparities and sort of what they are and what groups of people are affected by them. But we oftentimes hear sort of in parallel conversation, right? Both health disparity and the term health care disparity. And so are they different?
Not sort of in terms, but again, healthcare disparities, they're related. Healthcare disparities relates to how people are cared for.
Okay.
What kind of care you can get, what kind of access. But the health disparities are those real differences. They in terms of, usually it's the differences in the amount of disease. When we think about health disparities, we're thinking about the mortality rates. We're talking about and for COVID as an example, we're talking about infection rates. We're talking about disparities in how people live. The essential workers have to go to work. They may not have homes where they can be socially isolated. We're talking about the differences in the way they get help, transportation. I've heard people say that it takes 4 buses to get to a place to take a vaccine. It takes all day, or to get tested. So we're talking about those measurable differences in the status of people. We're talking about health care is really how people are cared for, the differences. Now, let me just say one thing about care. In 2003, the Institute of Medicine put out a report that talked about the differences in care. And in that report, it said that African Americans get worse care, even if they are able to pay, or they are in spite of their level of insurance.
Wow.
A new report was just published in the Proceedings of the National Academy of Sciences that said African American babies are 3 times more likely to die if they are cared for by white physicians. So we're talking about, when we talk about care, we've got work to do on that side too. So schools of medicine need to be aware of those studies, and we need to integrate health disparities and equity in our curricula and in our training, and really, really do a better job of education and sensitivity and concordance, looking at concordance. And then we need to do a better job of getting students of color, of all colors, races and ethnicities and backgrounds, into medicine and into positions that make policy and decisions about health. So it's not just, this just occurred, or these are the statistics. We have a very complex situation when we're looking at health equity and health outcomes and health care outcomes. Yes.
It occurs to me when you were talking about even how people live that perhaps are disproportionately affected by COVID, for example, you cited. It occurs to me that they may also be living in sort of non-natural families, right? Not the sort of traditional nuclear family that many of us may have grown up in and around. It may be a multi-generational household.
Yes.
With beyond multiple generations, there may also be, as you cite, many folks who may be living communally together.
Absolutely.
Across multiple generations, which sort of gets to my next question is, we see this now beginning to affect, I don't know that this is new, it's beginning to affect a generation, multi-generations within our population, right?
Yes, so again, it is so important to have discussions like this because understanding cultures is critical to improving population health. So yes, there are populations who tend to live more so intergenerationally, and that's a good thing in their culture. That's a very good thing.
Right.
And yet, unless we make health and healthcare much more equitable, that becomes a challenge for good outcomes. And so yes, I think that as we think about how we engage these communities, we need to do it with an understanding of we need to meet you where you are, which is what equity is about, not equality, but equity. And so all of our communities are important. Their cultures are important. And again, I say that we have to do a better job with service providers and educators in helping our next generations to understand that these cultures are significant. But
Sure.
how do we help? How do we bring resources and good outcomes to these communities without discrimination?
Sure. I know from my own experience in our own organization, we like to say that if it exists within our community, we have touched it in some way. We have cared for it in some way, which makes it incumbent upon us as a healthcare organization to understand the different cultural approaches or ethnic approaches to end of life care, for example. And that's just as it relates to our own organization. But having the ability to understand their approach really helps inform the way we even go about
Yes.
determining the provision of care.
Mhm.
Because our goal is to meet people, as you say, where they are. And part of that means that we have a responsibility to understand the context
Mhm.
in which they have lived and the tenets to which they have appended their beliefs.
Yes.
That's
Abs-
really important.
Absolutely.
Um,
We
go ahead.
get to do that, Trent, quite a bit in um, our Integrating Special Populations program in the Maya Angelou Center for Health Equity. This is a program that's funded by our Clinical Translational Science Institute. And we get to look at communities and some of their cultures and some of their practices because people want to conduct research with these different communities, of course. So we get to ask a lot of questions about how people think about study participation. What are barriers? What are motivations for participation? And what we know for sure is that we must take into account the history, those practices. And again, we have to meet those communities where they are. And if we don't, what will happen, or what has happened in the past much too often, is that many studies and clinical trials that we all need to improve health outcomes never reach their target enrollments. And studies show that often we don't reach our target enrollments is because we just don't take the time to understand those nuances in those communities. And so it's very important even from on that level.
Sure. So it's sort of taking, in the translational sense, it's taking it from the academic to the practical, right?
Absolutely.
I think that's what you're talking about. So along those same lines, and you're thinking about reaching them from a study perspective, even reaching them from a more sort of, I'll use the term boots on the ground, sort of at the bedside, for lack of a better term, mentality. What are the mechanisms you go by to reach those people? What does faith institutions play? What role do they play in helping reach these people and gaining trust? Because I think we're sort of talking a little bit on the fringes of do these populations of people trust us, either as an organization or the healthcare system, to do what we say we're going to do, right?
Absolutely. I'm so happy you asked that question because one of the things that we've done in the Maya Angelou Center for Health Equity is to partner with, of course, our faith health group here at Wake, but we have done an extra thing with African Americans because they are particularly disproportionately underrepresented in studies and clinical trials. And again, in our ISP program, one of our goals is to increase interest and motivation. And the way we do that is through education and improving what communities know about science and studies and research and health in a way to build trustworthiness. So we like to situate trust in a trustworthiness context, if you will. And the way we want to do that is to say that Wake is here. We recognize some of the atrocities in science and medicine that have occurred here and at other medical schools. But we're here now to be a much more positive and much more giving resource than we have been in the past. So we've spent an inordinate amount of time thinking about how we as researchers and how we as an institution can become much more trustworthy of communities' time and involvement in our studies. So one of the things we did in our center, is to engage 109 African-American churches in the region. Wow. And we said that we wanted to first start out with improving the health of their congregations. And we wanted to do that through health promotion. So we wanted to create, in each of those churches, we wanted to create health ministries, and that we would partner with the School of Medicine, with our affiliate faculty, with people like you who could help us bring health and awareness into these churches, in their spaces. So we begin with what we do for them before we begin to ask them to do anything. And so we wanted to do that as a first-rate way to begin to create trustworthiness in those communities. Once we are able to do that, we can then open dialogue about study participation, other resource access to Wake Forest. And so I'm so excited about that. Our pastors and faith leaders, it is across faith, it's not just Baptist people. Really excited that we have now connected with these, and they're really interested in improving health in their congregations and surrounding communities. So we have engaged them in very powerful conversations, and we're asking them to help us, to lead us and guide us through a strong health-related partnership.
You know, about 4 years ago, Harvard University Medical School released a study on the intersect between health and well-being and spirituality, and yes. And one of the key takeaways from it was, in absence of a conversation with clergy, people, if they have strong faith traditions, they are far more likely, to experience care that is inconsistent with what they're looking for, or what their values may actually be. Yeah. And so I know most recently, just if I may, if you'll indulge me for just a moment, in a recent conversation I had with a lady in our own office who we were talking, this is about a COVID vaccine, and we were having a conversation related to its safety and efficacy and all of that. And it didn't matter what I sent her or gave her. It mattered that her pastor had that conversation with her congregation at her most recent time at church. And these are her exact words to me. He said he couldn't tell us whether or not to take it or not, but he said he was going to. And she said, in her own words, that has weighed heavily on my heart and my mind. Now, I'd connected her with all the scientific sort of accessibly information that she could find, that I could find, to help her make a well-informed decision. But that didn't matter. What mattered is that she had a conversation in her faith community. That mattered most to her. That was powerful. That's powerful, I think.
And it's so important to know what who those influencers are, and to work respectfully and in a dignified way with them. We just had a webinar a couple of weeks ago. We had 23,000 people to access that webinar on vaccine uptake. These were all African Americans. I bet maybe 95% African Americans. And we did that because the bishop of an organization actually accessed all of his thousands of churches and said, be on this webinar. tonight at 7 o'clock. And so because he did that, we were able to connect with so many people. We had people in the chat saying, now I'm going to go ahead and take the vaccine. He actually had a little video on that webinar too, showing his getting the vaccine. So understanding these influences and working with them with reciprocity in ways that they win and we win and our communities win is so important. And we're learning. They're teaching us a lot.
Yeah, it's as much about acceptance as it is about trust, right? I think
Absolutely.
they sort of go hand in hand. Yeah, I mean, it's as much about both of those. So it's so interesting to me, you know, what are the solutions that you begin to see happening in the community, in the region? Where do you see us going from here?
So that's a great question around health. So one of the things that I've been reading quite a bit about is how this community we're in Region 3, how this region looks in terms of disparities in health, in terms of life expectancy, in terms of education attainment. So the first step always is to become educated about what's happening, and then begin to understand what it will take to move some needles. And that will take all of us, quite frankly. We have been working closely with an elementary school just to get vaccines, so that the kids can stay in school. So there's so many, it's multi-layered. We are working, of course, with influencers all over the community. And it's hard because for a small center like ours, to really know where to enter the pipeline. But we believe with voices from the community, and we've done quite a bit of that, hearing communities and understanding their priorities, and then trying to connect with the appropriate people who are already working on some of these social drivers of health. And I think one of the hardest things, Trent, is to make sure we're not isolated, to make sure that we're connecting with the right people, make sure we're not trying to reinvent wheels. We often get isolated and siloed. But the city is making some positive moves, and we're just going to try to connect as well as we can. And we're going to use those 4 pillars that I talked about to improve access, to improve that next generation of people who will be responsible for good health outcomes. Certainly the awareness and literacy around health and management of health, management of disease. So we have a lot on our plates right now, but I think understanding what the true disparities are in our region and working with state and federal agencies to try to help move the needle, as well as business owners. It's going to take a lot to really address those social determinants. I've been asking other people that very same question, and I think there's a lot of concern about how we really do impact communities, because that's where it has to happen.
Yeah, at the grassroots level, I couldn't agree more. It absolutely does, because if we thinking about acceptance and trust, if we're unable to make inroads with at the census tract level, for example, to use an urban planning term, if we aren't able to connect with the neighborhoods and the streets around where we know disparities exist, then how can we begin to think about even contemplating and crafting strategies that really begin to affect them in a positive way?
Absolutely. And we have too many distressed communities, communities with low socioeconomic status, communities with environmental hazards, communities where the unemployment rate is disproportionately high. So we have, where the education attainment is so low. And students, there are areas in East Winston-Salem, as an example, where the 3rd grade reading level is 27% among African-American kids. Wow. So there are just atrocities And that kid is not going, the kid who can't read at the third grade is probably not going to read at eighth grade or 12th grade. And they'll never get into Wake Forest or Winston-Salem State University with that kind of reading problem. So and I know that there are efforts to improve that here, but people need to know that those kinds of disparities exist. And not only will that kid not be able to go to college and not get a good job maybe, and that child may already be in poverty and will remain in poverty. And then the health outcomes of that kid will be poor, which will cost that kid's family, and all of us, quite frankly.
Coming back to that $93 billion nationally that we sort of began our conversation with, and it really does begin have a cumulative effect. It sounds like what you're talking about and describing is an incredibly holistic approach that really is incumbent upon all of us, not just as individuals, but organizations like ours and centers like yours and learning institutions like Wake Forest School of Medicine to really begin to affect all of this.
And again, I so applaud you for this series to help others understand, what this landscape looks like. And I think awareness will help all of us to do better.
I appreciate that. I do. Our goal is to really help people who are listening to us and connected with our organization to understand that the health disparities or social disparities in our communities may be far more pervasive than we thought.
Yes.
And may affect different groups that we don't normally associate because of a stereotypical sort of bias that we may have.
Yes.
It has a wide-ranging effect on a lot of different populations.
Absolutely, and we do a good job of separating people based on what we think we think they need to be, but we really don't know those nuances in those groups and those communities. We simply don't know enough of about that, and so we make assumptions. Right. But the facts are always better, and studies, we need more studies, more population studies in that, so that we can understand the differences and the commonalities. I think is another area. Is what do all of us need? All of us need certain basic things.
Sure.
And opportunities. Yeah.
And I suspect you talked a little bit about Winston-Salem, which I know is where the center is. You've spent a lot of time at A&T in Greensboro. And we are in High Point, though we serve a very large segment of the Piedmont Triad region, 8 counties of the Piedmont Triad. So talk a little bit about High Point. I suspect that their shared experience is not unlike that of Winston-Salem or Greensboro, because the commonalities are just that, common.
Absolutely. And High Point has some very poor counties. Has very poor communities. There's High Point University, and it's great, but there are communities around High Point University that are really distressed. And so we have pastors there in our network that we're working with to improve health ministries there. We certainly want to move out. Our Triad Pastors Network is just that. It's a network, but it's a bridge to community. And so we will be working with the pastors there to connect us to not only their congregants, but the people around them. So we will have a large footprint in High Point. And not just African Americans. Our network is African Americans, so we just started with that group. But we're not just an African American center. So yes, we will be in High Point.
Very good. Well, we look forward to partnering with you all as you find your way in High Point, and partnering with you all on a number of important initiatives that I know you all are working on. We believe our responsibility extends not only to the health and well-being of the community, but also to raise the level of awareness and insights that the community may need about the community that they live in and that surrounds them.
Absolutely. And we are looking forward to partnering with you on that. So we're going to be thinking about that immediately after this call.
Yeah. So Dr. Byrd, as we think back over the last 42 minutes or so of our conversation, is there something that you feel like you really want people to know? And one of the things that I know that we have talked about is the North Carolina Office of Minority Health. We're talking about not only a regional issue or a city-based issue. There's even a state office that has been established to begin addressing these issues, because we understand that has such an impact on the lives of North Carolinians, and not just on their lives, but also on the cost of healthcare that's delivered, and the way we interact with them, going back to that $93 billion nationally. So do you want to talk a little bit about that, and then any other things that you'd like our viewers and listeners really to take away from our conversation today?
Well, yes, thank you. And let me say that office is the Office of Minority Health and Health Disparities, and its director is Mr. Cornell Wright. And we are working closely with Cornell, particularly with the COVID vaccine uptake and testing. And I would encourage anyone who is interested in health disparities to visit that website. And they have a wonderful report that they put out just a couple of years ago on the disparities in health. And I believe Ryan has put that up in the chat. So I would encourage everyone to take a look at that and to get involved in some way. I conduct research in Alzheimer's genetics, and that's a huge disparity. Alzheimer's occurs twice more in African Americans, 1.5 times more in Hispanic Americans. 2/3 of cases are in women. We were just talking about not only ethnic and racial groups, but also other differences. And we're looking for people to assist us with that project, to get interested and involved, help us get people to resources. Certainly, Trent, people who have folks who have this disease in their families certainly reach out to hospice often for not only for information, but opportunities to get connected. And so this is a disease that we're very happy to be partnering with Laura Baker and Suzanne Kraft here at the ADRC, Alzheimer's Disease Research Center. And this is a disease that's only going to get worse because we're living longer. Mm-hmm. We have fewer children to take care of us. Mm-hmm. We benefit from all of the technology and medicine that help us with that. So we're living longer. And so this is one disease that's going to triple unless there's a big intervention or cure. There's no cure for it. So at this point. So with that one, there are many others. There are disparities with diabetes, high blood pressure, cancer, and the big thing that we like for people to leave with today is that these diseases don't just happen. They happen because of these social drivers of health, the way people live, where they live, access to care. So all of these things come together. And I would just encourage anybody to get involved in understanding these social drivers and understanding how they relate to health. And then figure out how we all can help in some way. And if it's at the community-based level, great. If it's at an academic or it's community-based organization level, we all can do something. And I would just love for all of us to get involved in improving the lives of everybody so that they have equitable chances of good health outcomes.
I certainly hear that as a tremendous inspiration and challenge at the same time to everybody who is connected with our organization, or maybe listening to this, watching this today, or listening to this later at a later time. I certainly hear that, and I think that it is incumbent upon all of us to do our part. That's something that I've said so very much during this time of COVID, right? That we must all do our part to care for each other. And I think this is perhaps one silver lining in an otherwise incredibly dark and ominous cloud that we can take out of the last year, is that we all may emerge from this with a sense of belonging and sense of responsibility more to one another.
Yes.
And our ability to truly impact what happens to the people around us, whether they're directly connected with us or even people that we may not always see or think about, but know are equally important. So
absolutely.
I appreciate this time with you. I see our host has magically reappeared, Ryan Biagini, which means we are running up on time. I thank you, Dr. Byrd, for the privilege of having this opportunity to have this incredibly insightful conversation with you. I am so very appreciative of that. Ryan?
Well, thank you for the opportunity. I look forward to working with you and Raya in the future, and certainly with Hospice.
Thank you.
Thank you.
Well, thank you both for allowing us to sit in on this conversation, kind of a fly on the wall. From this 45-minute conversation alone, I feel like I have a clear understanding of what health disparities are and feel even more informed regarding the breadth of their impact on our community. So thank you for contributing to that awareness. Dr. Byrd, we appreciate your willingness to share your knowledge and your expertise on this subject. And we thank you for all the excellent work that you and your team are doing at the Maya Angelou Center for Health Equity and at Wake Forest University.
Thank you, Ryan. It's been my pleasure.
Thank you.
I'd also like to thank all of our listeners who have joined us today for our discussion exploring our community defining health disparities. As we continue this e-series, we are pleased to inform you that both this series as well as all of our future e-series installments are available on podcast for download at both our website under resources and on SoundCloud, Google, and Apple Podcasts. We hope that you will tune in next time as we welcome special guest Giselle Montse, director of the YWCA Latino Family Center, for our conversation exploring our community, identifying health disparities. Together, Trent and Giselle will identify health disparities specific to the Latino community and common concerns related to healthcare accessibility. We hope you will join us. Until then, I'm Ryan Biagini, and this has been the E-Series.